Have any of you experienced anyone with depression or anxiety or mania? You may have. Some of these terms are overused in our culture. People will assume they have a mood disorder because their moods change. And the reality is, if you have known anyone with a true mental health condition, it's more than just mood shifting or changing. There's a lot more signs, there's a lot more symptoms, and even some extremes. And so today we're going to go over normal mood changes in depression and mania, and what they look like, how they affect people. And this is important especially when you're diagnosing, which is what you're learning in this class, because you'll be needing to pick up on some of these things as you're dealing and working with clients. So, normal mood changes and depression and mania, what are they? Most people have experienced moods such as sadness and happiness, right? We idle between both, right? There is a level of extremes on either end. Moods exist on a continuum from normal to disordered and have emotional, cognitive, and behavioral components. Because as we know, with certain moods, behavior then is reflected as a result of it, with anger, with sadness, with happiness, with joy, with discontentment, despair, hopelessness. Usually there's a level of behavior that you've seen as a result of some of those feelings. Now, some of us are able to have self-control, and the amount that our moods affect us isn't necessarily always seen in our behavior because we're able to handle it or work through coping skills or tools to navigate through those things. However, some people have a really hard time figuring out how to navigate some of these moods. Sometimes moods are so extreme when we see depression and or mania. So depressive and bipolar disorders, a major depressive episode, so involves a period of time, typically at least 2 weeks, but usually longer, in which a person experiences sad or empty moods most of the day, nearly every day. The sadness is usually intense to the point that the person has trouble functioning daily life. What does that look like? So sometimes when we are doing therapy with people, depending on the site that you work at, you will be asked to do a mental status exam for clients. What is that? It's a way of looking at what is going on with the client based on how they come into the office. Do they have good hygiene? Do they smell? Do they seem to have organized thoughts? What is their overall disposition? Do they seem very flat? Do they seem sad? Do they seem over the top happy? Do they look disheveled? Are they not making sense? These are the things that we're looking for because these are signs like something's not right. You might have clients that have maybe said they've struggled with depression and then maybe aren't in a depressive episode when you start seeing them, and they may transition into that. Being able to navigate that with clients is important. Being able to say, okay, I'm noticing some changes, something seems different. What's going on with you? That's important. Like, especially when we've been seeing people and we're noticing a change or a shift, we got to rule out some things to figure out what's going on. We always want to rule out medical, right? Because people could have health things going on, and that could be causing a mood shift or a behavior change. Now, sometimes that could be something that's hormonal. That could be something that is cognitively going on, like Alzheimer's or dementia. It could be a diabetic type situation. It could be a thyroid situation. We are not doctors, so medical decisions are only left to doctors because that's outside our scope. So if you're noticing something changing for a client, like sleep or even sexual activity, like their body's not working how it used to, headaches all the time, things like that, always say, you know what, I really suggest you go see a doctor. We aren't doctors. We can't prescribe medication. We could look up WebMD, but that doesn't make us a doctor. So I would say always, if you have a client that's coming in and has experienced some changes, they were one way, now they're acting different, I would suggest they see a clinician, as far as like meaning a doctor. And then that way it's like, let's rule out all the things. Sometimes like a vitamin deficiency or things of that nature can cause people to behave a type of way. Body aches, things like that. We don't want to rule out those things, because if there's something going on physically, that's affecting our emotional state, right? And so, we want to look at life circumstances too, like what's going on with them at life. Have they recently lost somebody, meaning grief? Are they going through a divorce? Is there a major life significant change, like a job situation or job failure? Are they struggling with something with a child or friendships or feeling lonely? Taking all that into consideration and being able to look at the person holistically is really important, because we want to be able to really try to dissect and navigate what could be going on with the person. A major depressive disorder involves a long period during which a person may experience multiple major depressive episodes. Taking a great history of clients is really important, because as we know, genetics plays a factor in how we feel, not only physically, but how we operate emotionally and mentally. As we know, there are genetic conditions, mental health conditions that can run in families. So asking questions like, has anyone in your family experienced depression? Did anybody go through bouts of like not getting out of bed, or always seeming sad or tearful all the time? Being able to know some of this information might help educate clients and help them understand what was maybe going on for a loved one, so they can better understand themselves. A persistent depressive disorder is chronic for 2 years. That's something that used to be known as dysthymia. It's 2 years of chronic feelings of depression, not maybe to the extremes of some depressive situations, but like a consistent level of depression. Sometimes it's hard to navigate that when someone's just felt like that for so long, they think this is just life. So letting people know, like, actually, that's not just life. Let's work through that and let's figure out what your options are is always good. Now, when we talk about medication, people sometimes can get very weird, and even defensive. Medication is a personal choice as in regards to mental health medication. We definitely can suggest, I think you should consult a psychiatrist or your primary care physician about these things that are going on, to see if meds are an option. I always tell clients, I believe in meds, but I also know that's a personal choice. I do believe they can help people, but my mind, meds are not to take away therapy. Meds are a way to take the edge off so clients can utilize their tools that are in their tool belt to help work through whatever it is that they're facing, whether it be a depressive type disorder or more of an anxiety type disorder. Meds, in my mind, help kind of clear the fog so that we can really start using and honing in on our skills. Meds may not be something we always need to take. It could be a seasonal thing, like a season of life that we're in, or it could be something that you just decide, I'm always going to have to take this. With some more chronic mental health conditions, the reality is, I think sometimes for the best results, medication is something that would be needed. However, that is a personal choice. I'm not going to force that upon anyone, nor are you, because that's not what we're there to do. So just be mindful of that. That's a client decision. Now, when I have clients that are really struggling chronically with mental health conditions, I really try to help them, navigate through the pros and cons of such things, because sometimes they've tried everything, it's still not working, and that's the one thing left that they don't need to try. So maybe weighing the pros and cons, all those kinds of things will help with just making that kind of decision. That's why too, at whatever sites or facilities you work, if you run into working with psychiatrists at all, just taking note of psychiatrists that you've been really pleased with working with, just to have a good referral source for clients. When the time does come and they do want a referral, you might have some people you could suggest, assuming it's within their healthcare plan. Because sometimes, it's very intimidating going to see a psychiatrist, and you really want someone that's going to listen to their patients, take in what's going on with them, and allowing them to feel really seen. Okay. Here's a couple other depressive disorders that come up. Obviously, we know postpartum, peripartum, which is, before or after. It happens during pregnancy or the weeks after childbirth. Very common in women. and taking that stuff into consideration, again, with history, knowing what's going on with the client to really know what's being brought to the table based on what they're experiencing. Premenstrual dysphoric disorder. It's something that happens for women. I have a lot of female clients that have these things that go on, and their mood, our cycle involves a lot of hormones, and their mood drops, and they really struggle the week before their period. Some women, it's the week after, and as we know, different hormones surge and drop around those times, and some women are very sensitive to that. And so just being aware that's something you can talk to your OBGYN about, and consult, again, a physician. We are not doctors. We cannot prescribe. We can't even prescribe oils and things like that because, God forbid, someone's allergic. You just really hurt them. And so we can't suggest anything that's outside of our scope of practice. Okay, so please be mindful of that. We are not doctors. We could really know a lot about nutrition or really know a lot about oils or things of that nature, but it's not our job to educate our clients on those things because that's not what they're coming in for. They're coming in for therapy. So please keep that in mind when you're working with clients. What is a manic episode? Okay, a manic episode is extreme. Okay, when we have mania, the person feels almost euphoric or high, not high like high on drugs, but like they're invincible. Like, we have a great example of this in common media these days is Kanye West. He is bipolar. And we've seen some erratic behavior or probably things that he's done when he's feeling really, really great about them himself. Manic, extreme. Sometimes mania includes spending money, maybe doing some high risk behavior, high sexual behavior. It could involve drugs. It could involve taking risks that maybe you wouldn't normally take. It could mean not sleeping. People assuming they use this constructively could get a lot done because they don't need the sleep because they're just like high on life, but the letdown from that then could be a hypomanic episode, but it's less intense. Inflated, it could be inflated self-esteem. The opposite though of manic, I would say, would be a depressive episode. And so when you see people swing from high highs like that to low lows, that's where we need to take into consideration a bipolar disorder, things of that nature. Symptoms may include inflated self-esteem or grandiosity, like I'm the best at everything. I can rule the world, like kind of like not a very accurate sense of self, being more talkative than usual, maybe even a pressure to talk, feeling like thoughts are racing, decreased need for sleep, distractibility, involvement in activities with high potential for negative consequences, especially like high risk behavior, whether it be unprotected sex, having sex with a lot of partners, even spending money, spending money that they don't have, just a lot of consequences when it's not realized that's what's going on. Bipolar 1 disorder, more than one or more manic episodes. Bipolar 2 disorder, episodes of hypomania that alternate with episodes of major depression. Encyclothymic disorder, symptoms of hypomania and depression that fluctuate over at least a 2-year period. So as you're navigating with clients a diagnosis, it's being able to take into consideration all the factors and symptoms. That's why the DSM is so important as you look at all the criteria. Now, I think it's hard with bipolar disorder. A lot of times people are eager to diagnose younger children with bipolar disorder, sometimes teenagers. Now, bipolar disorder does have a tendency to run in families, so that's where a proper history is important. Also, I don't know if you know very many teens, but teens are going through a lot in prepubescent stages and then in puberty. A lot of emotional shifts, a lot of hormone stuff going on. I think sometimes kids are misdiagnosed because there's just so much extreme emotional stuff that's going on for them. Also, if any kid is doing drugs alter our emotional state. So with that being said, we need to be very conscientious of making sure we're getting a good history and good information on what's going on for kids, because kids could be struggling with addiction, and that's why their moods are alternating so much. And we see that even with vaping, we see that with using excessive marijuana, alcohol, and any sort of upper, right? Like any sort of upper, like cocaine, speed, uh, if they're using prescription drugs inappropriately, kids' moods and things are going to shift. That will be the same of adults. And so those are kinds of things that rule out certain diagnoses if that kind of behavior is going on. So again, this is why a good diagnosis is, or I'm sorry, a good history is so important, because we want to be able to weigh these things out. So suicide, obviously very serious, something we have to take very seriously. It is important. It is imperative that whatever site you work at, you know the plan, you know what you're to do. If someone is suicidal and or is wanting to is suicidal, wanting to harm themselves, is talking about harming themselves, has a plan, you need to make sure you know what to do. Suicide is commonly associated with depressive and bipolar disorders, but also occurs in conjunction with other disorders, which is true. Suicidality can be viewed along a spectrum from thoughts of suicide to actual death. We talk about suicidal ideation a lot, SI, suicidal behavior, suicidal attempts, and suicidal completion. These are things that we want to make sure, again, when we're taking a history, we're getting good information on what has happened in the past, so we can kind of know tools and make sure we have the right plans in place for someone who has struggled with suicidal ideation and or a plan. Again, we're just wanting to make sure we are on top of things as best as we can. We cannot control other people, but we need to take threats of harm to self very seriously. Even if it is attention-seeking behavior, it's not our job to rule that out. That's the job of the people at the inpatient hospital. So even with parents, when they're dealing with teens that are threatening to harm themselves, I mean, take them into the hospital. Now, I know that's not easy. I know that is scary. I know not all emergency rooms, maybe there's not beds available, but you need to it's a way to communicate to the person who's saying these things like, look, I do not take this lightly. Your life is important to me. And when you say these things, I'm going to hold you to it. And that can be really hard and or difficult, but it's really important. Okay. So epidemiology of depressive and bipolar disorders. Prevalence of major depressive disorder worldwide is 5% among adults. Lifetime prevalence of dysthymia is 1% to 6%. That's the one I talked about, like 2 years of kind of feeling a type of way. Common during adolescence. Depression is more common in higher income countries compared to lower income countries. Why do you think that is? I think there's a comparison factor, what I think I should have versus what I have. And maybe in lower income countries, we're surviving. We're happy with there's more of a level of contentment probably. Less is more is a great way of looking at life. And I think when we feel like we should have more or wanting more, we look at social media. Just heard some stats today at church actually about just some things with young people of today, and just how much depression and suicidality has increased due to probably since cell phones have been really made prevalent in our culture, especially among young people. I think there's so much with phones that have been totally toxic. Not all technology is bad, but our reliancy on it probably has created a lot of mental health issues. So, just some food for thought there. And higher among white populations. Okay. So suicide, 700,000 suicides worldwide each year, leading cause of death in the United States, rates highest in Eastern Europe. Risk is 20 to 30 times higher among those with bipolar disorder. Remember, there's that high risk behavior. I'm on top of the world, all those kinds of things. And then idling with those very low lows can create for some major challenges. Again, with the stats I heard today, I think the third leading cause of death in young people of today is suicide. Something to be mindful of, very scary. And most people who attempt or succeed in suicide regret it, partway through. But once it's already been initiated, there's no turning back in certain circumstances. So stigma associated with depressive and bipolar disorders. I think there is a lot of stigma in my clients who have bipolar disorder, and I think they really struggle with finding partners and feeling like people automatically will write them off or not want to be with them as a result of their polarity. People with these depressive and bipolar disorders feel a stigma of shame, possibly discrimination. And I think it's because of a lack of information and knowledge. And like, again, if treated appropriately, it can be manageable. It's when it's untreated and maybe the person doesn't have coping skills, that's where it becomes very difficult. And that's where it can be majorly problematic. So prevention. Genetics, like I mentioned, we want to make sure like we're being aware of genetic components in regards to some of these disorders. Brain features in depression, reduced activity in prefrontal and other cortical areas, difference in the size of the amygdala, hippocampus, subtle damage to the white matter, basal ganglia, and pons. The amygdala, too, is where we hold trauma. Trauma can definitely cause depression. And that's, again, going back to history, asking about major life events and or things that have been triggering to them that could be causing what's happening right now, whether it be, again, loss or a rape or sexual assault that happened, things that have caused something very traumatic to them. Brain features in bipolar disorder, heightened activity in the anterior cingulate, increased size of the putamen related to mania, reduced white and gray matter, neurochemical and hormonal features, serotonin and dopamine implicated in depression, dopamine and glutamate implicated in bipolar disorders. There's sleep deficiencies, again, in a manic state. You can be not sleeping. I think what's interesting in signs of depression, you could have things like sleeping too much, sleeping too little, eating too much, eating too little. It's almost like the extremes on either side could be signs of depression. This is what's so great about when you start seeing clients, you're going to be under supervision. And why supervision is so awesome is that you have someone you can talk through and talk to about your cases to really navigate these things, to try to better understand what could be going on with someone. So you're not on your own. You're not just tossed out there with no one to kind of help you. You will have help. You will have someone kind of guiding you through this process. A great asset. Something I really enjoy doing with my clinicians that work for me. And I think it's something that you should hopefully feel comfortable and secure in on this part of the journey, because there is a lot to decipher. There's a lot to take into consideration, and we don't want to be flippant with our diagnosis. Now, granted, when we're billing insurance, we have to have a diagnosis on first session, but we can always change that, right, as we get to know someone. So maybe we start with something a little less intense, and then we move into something that might be more accurate for the person as we get to know them better. Okay. So environmental risk factors for depressive and bipolar disorders and suicide, stressful life events, like I talked about, abuse, childhood abuse, systemic, meaning, maybe that's not the right word, process, like meaning like it's happened over years of time of abuse, negative thought pattern, no self-worth, hopelessness, basing our success and failures on the approval of others, not seeing value, learned helplessness, all things that contribute to suicide, social skill deficits, communication problems, relationship or marital conflicts, family factors, maybe there's not a good attachment, parenting issues with the people that raise them, cultural factors are high among immigrant and migrant populations. As far as depression and evolutionary factors, certain symptoms of depression may aid in adaptation. It's hard to adjust. I think, sometimes people are very often to say things about SI or harm to self, not really taking it into consideration. But like I said, we really have to keep people honest with that. If someone is making those kinds of remarks, we have to go through the protocol regardless of the seriousness of it. Doesn't matter, because all it takes is one time, right? So we have to be aware and on guard and ready to act, because we need to take that seriously. Like, now some people will say things very flippantly, like, I just want to die. It's like, okay, like, we can decipher those kinds of things. Or someone's like, you know what, if I were just to not wake up tomorrow, I'd be okay. I think it'd be okay. Like, that's different than an active plan of suicide, right? But it's still something we got to work through and talk about. So, again, not trying to diminish that seriousness, but we have to kind of work through, like, well, what does that mean? What does that look like? Do you have a plan? Is it an active plan? Because we really want to keep our clients safe. We want to keep the people around them safe. And we have to take those things into consideration. That's part of our job. That's part of being a mandated reporter. Harm to self, harm to others. Those are the things that we have to look into. Child abuse, elder abuse, right? We want to make sure people around our clients are safe. Okay. Here's something, possible developmental pathway of depression, biology, right? Family problems, stressful life events, cognitive stress, and behavioral vulnerabilities. So I'm going to leave us there. I hope this was helpful for you. It's definitely going to come up as you work with people. We hold a very special place, like I've mentioned, in our clients' lives. And to be able to navigate this with them is huge, and help them not to feel so alone, because this can feel very isolating. But to be able to navigate this with them in a way and in a fashion where they don't feel alone and they don't feel isolated or weird or strange is huge. And so I'm sure as you guys all enter practicum eventually and start seeing your own clients, take these things into consideration. It's not something to take lightly, and it will be definitely something you will see. Have a good week, guys.